Hello and welcome everyone. I'm Noah Reed, Vice President of Sales and Marketing for Precision Analytical, creators of the Dutch Test. This month, we have the opportunity to bring you a live Q&A session with Dr. Debbie Rice and Dr. Kelly Ruef. They're joining us today to answer some of your questions about women's health and fertility. As a reminder, our original webinar with Dr. Demiri has been postponed, but we will share more details on that when we get that rescheduled. As soon as we have those details, we'll let you know. Many of you have already submitted questions ahead of time, so there's a lot to cover today. And remember that Dutch providers can also schedule a 30-minute consultation with one of our clinical consultants through your provider portal to discuss your patient's results. All registrants will also receive a recording of today's session, so look for that in your inboxes tomorrow. If you're not already familiar with Precision Analytical and the Dutch test, Dutch stands for Dried Urine Tests for Comprehensive Hormones. It is a group of validated tests that provide the most complete evaluation of sex and adrenal hormones, including metabolites. This simple and convenient at-home collection for patients and support on every comprehensive report from a team of hormone experts puts you in the driver's seat to helping solve your patient's most complex hormone issues. Registering as a Dutch provider is very easy. So if you sign up today, you'll receive 50% off up to your first 5 kits, plus free clinical consults, video tutorials, patient referrals, and expert hormone education. To sign up, just click the link we've posted in the chat and complete the Become a Provider form on our website. After you complete the form, someone from our team will set up a one-on-one appointment to answer all your questions and walk you through the onboarding process. To get even more hormone education, check out the Dutch podcast, which dropped today as well. Wherever you get your podcast, each week you'll hear amazing conversations and insights from the leaders in functional medicine. Listen back to last week's episode with the basics of estrogen with Dr. Rice and catch up on this week's episode on female androgens with Dr. Kelly. Subscribe to the Dutch podcast on your favorite streaming app and visit dutchtest.com/podcast to learn more about the show. I would love it if you'd also rate us on any of those podcast apps. That'd be great. Remember, Dr. Ruef and Dr. Rice are doctors, but they're not your doctor. The contents of this webinar are for educational and informational purposes only. The information is not to be interpreted as or mistaken for clinical advice. Please consult a medical professional or healthcare provider for medical advice, diagnosis, or treatment. Patients can find a Dutch provider on our website by clicking the Find a Provider button at the top of the page. And now, let me introduce you to today's speaker. Dr. Debbie Rice is the Director of Clinical Education for Precision Analytical and practices part-time as a naturopathic doctor where she focuses care on pediatric health, hormone health, thyroid health, and adrenal health. She has had experience working with communities in need, both in the United States and internationally. Her training has been primarily in women's health, pediatric care, hormone therapy, and hormone function. Dr. Kelly Ruef is a licensed naturopathic doctor who completed her medical education at the National University of Natural Medicine in Portland, Oregon. She also completed a residency at Pearl Natural Health in downtown Portland, where she specialized in inflammatory bowel diseases and women's health. For undergraduate education, Dr. Ruef received a Bachelor of Science degree in biochemistry and cell biology with a minor in cognitive neuroscience from the University of California, San Diego. Welcome to today's presentation. We have a lot of questions, so let's jump to them. And I'm proud that I did not cough at all during that intro. So let's start with the first question here. A recent patient with cycle mapping and the Dutch Plus. On cycle mapping, progesterone was adequate, but estradiol and estrone were low. I believe that this may be contributing to difficulty conceiving due to thin endometrium. CAR within range on the Dutch Plus. Recommendations for increasing estrogen. We've discussed some weight gain. She has a low BMI, healthy fat and omega-3 intake, pelvic massage, and phytoestrogens. Dr. Ruef, that question is to you.
All right, that's a great question to start out with. And thank you for the introduction. That was great. I'm happy you didn't cough either. I'm getting over being sick too, so hopefully I won't cough either. I got my tea right here. Okay, so let's summarize that again. So they did a cycle mapping and a Dutch Plus, and they said the progesterone looked adequate. So I would ask, what is adequate according to their definition? For me, when it comes to fertility, I like to see progesterone at its highest point on the Dutch Plus around 15 or 20. I believe that's nanograms per milligram. 15 or 20 is pretty good for fertility, and I like to see that the luteal phase is about 2 weeks or 14 days in length. Um, okay, they said estrogen was low, right? And they did a CAR, or cortisol awakening response, and that was within range. So it is true that estrogen is important for kind of priming that endometrium, right? If we don't have enough estrogen around, we might have a thinner endometrium. And so that could be an issue. It could affect fertility. I have seen some women with lower estrogen still get pregnant and have healthy pregnancies, carry to term. Um, so, let's see. They've discussed weight gain. She's got low BMI. We know very oftentimes when you have a low BMI, it can lead to lower sex hormones. If she does, in fact, have adequate progesterone, then we know that she ovulated and she had enough estrogen at one point to ovulate. Because you have to have a specific amount of estrogen surging for a specific amount of time in order to get that LH surge and that ovulation. But I still wonder about the quality of the egg. So they did healthy fats, omega-3, pelvic massage, and phytoestrogens. Okay, great. So I think they're on the right track with the low BMI. Low fat body percentage can contribute to lower sex hormones. So weight gain, if appropriate, can be helpful. I would also look at the androgens, because androgens, as we know, are really important for fertility. They support that follicle development, they support ovulation. And so a lot of times when there's low estrogen, I'm looking at the androgens. And if the androgens are low, then sometimes if you support the androgens, that in turn can support the follicle development. And we know that a healthy follicle makes healthy amounts of estrogen, right? So sometimes just supporting the androgens can be really beneficial for the follicle development and the estrogen levels. So a lot of times I'm looking at the androgens and I might be trying to help support the androgens. And again, weight gain can be helpful for androgens. We also know that regulating blood sugars can be great for androgens, stress reduction, lowering inflammation in the body, that can all be great for androgens. And there's some herbs out there like maca, tribulus, shatavari, ashwagandha, zinc also can be supportive. Let's see, besides that, I might look at her metabolized cortisol. So she said that her CAR, her cortisol awakening response, so her free cortisol in circulation looks good. And the CAR is more representative of like tissue levels of cortisol. And so the tissue levels of cortisol might be fine, but a lot of times you'll see low metabolized cortisol in these cases. And when you have low metabolized cortisol relative to a higher free cortisol in circulation, like a normal CAR, this can be a pattern of low body weight, hypothyroidism, suboptimal liver function, poor mitochondrial function. So it might give you a clue about things to work on. And a lot of times when you have low metabolized cortisol in a normal CAR or even a high CAR, sometimes these women will have low androgens, which kind of plays back into the follicle development, the fertility and the estrogen levels. Dr. Rice, did you want to add anything to that?
It looks like we lost your audio, Dr. Rice.
Well, I can keep going if that's helpful.
Yeah, why don't you go ahead and keep going, Dr. Ruef?
Okay. When it comes to estrogen levels and cycling, I also think about carbohydrates. A lot of women these days are taking out carbs. And for some women, they're really important for their cycling, for their fertility. So I'm not telling women to go and eat a bunch of pasta and bread and cookies and um, I don't know, donuts, every day, but just to get some of these complex carbs in their diet, like sweet potatoes, quinoa. Quinoa is an awesome source of carbs. Um, Gosh, what else? Maybe a little bit of rice. I might not add in wheat if they have a sensitivity to it or celiac, for example. And then, of course, you can always support the mitochondria. So sex hormone synthesis begins in the mitochondria. So when you have low sex hormones, you can always think about supporting those mitochondria. And there was a study, let me quote it here. They said mitochondrial dysfunction in a mouse model with high mitochondrial ROS, so that's reactive oxygen species generation, also results in infertility, defective folliculogenesis, and impaired ovulation. If you want to look it up, it's PMID 244955597. But supporting those mitochondria can be really important too for estrogen levels. I like that she's got the healthy fats in there. And another thing to think about, I mean, she did say she's doing the phytoestrogens. And there is a study where they looked at 100 different women with PCOS, and half of them they gave Clomid, and half of them they give black cohosh, 20 milligrams on cycle days 2 through 10. And the women that they gave the black cohosh to actually had increased rates of pregnancy, and they had a thicker endometrial lining. So we do know that some of these phytoestrogens can be supportive of the endometrial lining and can help with pregnancy.
Do we have you back, Dr. Rice?
I don't know. Can you hear me?
We can. Yes.
Yay!
I was just
Technology
going to
didn't defeat
say,
us today.
can we expand on what androgens are?
Yeah,
Yeah,
go
we
for it.
should.
So when Dr. Kelly is talking about androgens, we're talking about DHEA. So it's going to be like your DHEAS, your androsterone, your etioclanolone, your testosterone metabolites. And so, as she said, the androgens can be very, very influential in follicle development. So we want to look at all of those components, right? Not just the endometrium, but also how you're building and making an egg too. And the androgens are very important for that. So yes, totally.
And a little shameless plug, if you are interested more in the female androgens and how they're created, the female androgens edition of the Dutch podcast dropped today with Dr. Kelly Ruef. So you can go listen to that on any of your favorite streaming apps. Since we have you, Dr. Rice, and you are back, maybe you can kind of walk us through what are some of the key things that you look for on the Dutch test to determine fertility, if anything.
For fertility, all of the above. No, really, I mean, when we're looking at fertility, and so this is where, and I think this may actually hit on one of the questions, is where like we've done the testing, the estrogen is in the right range, in cycle mapping, the estrogen looks good, her progesterone looks good, right? Like we've tested the sperm, partner sperm looks good. Like what else do we do? When we're looking at fertility, I also really want to look at stress, right? So we want to make sure that estrogen and progesterone are balancing each other. We want to make sure that the androgens are producing a healthy level because of that follicular development. But we also really want to look at stress because stress is going to be a big thing, right? Like if you're running from that saber-toothed tiger, your body is not going to be focusing, even if it has really good levels of estrogen, really good levels of progesterone. Its main focus is keeping you safe and it's keeping you away from that saber-toothed tiger. So stress, right? Like your metabolized cortisol, your melatonin, your free cortisol diurnal pattern throughout the day, your oxidative stress, right? Like this is what we look at for what we call like the zero trimester, right? Like when we're prepping someone to get pregnant, we want to make sure that all of those things, oxidative, environmental exposures, how your cycle is, how your estrogen and progesterone are functioning, and what your cortisol is doing. Not only how much you're making, but what your cortisol is doing throughout the day. So
Wonderful. How about you, Dr. Kelly? Anything in particular you look at when starting at the top and working your way down?
Yeah, I totally agree with Dr. Rice. All of those are really important. A lot of times, of course, I'm looking at the progesterone and the estrogen and the androgens. And with the Dutch test, it's important with the androgens on page 3, you want to look at the age-dependent ranges. And even if I have a woman in her early 40s, I'll still look at that 20 to 39 age range for the androgens instead of the, 40 to 60? Because I'd rather, if she's trying to get pregnant, especially, I'd rather her have the androgens of a 35-year-old than a 55-year-old. So I'll just point that out.
100% agree.
If you are looking for healthy ovulation on the Dutch test, what would that look like?
Okay, also a really, really, really good question. So with a healthy ovulation, if they ovulated, they're going to be making progesterone. And like I said before, I like to see that around 15 to 20. on the Dutch test. And that, I should mention, is the serum equivalent. So that's on page 1 in the progesterone dial. We've calculated the serum equivalent. So if she went in and got her blood drawn on that day, hopefully her progesterone would be around 15 or 20. Besides that, I might look at the androgen levels again and the estrogen. It might give us a little bit more of an idea about the quality of the egg too. But besides that, everything on the Dutch test kind of feeds into what is the overall health of the person. And the overall health of the person is going to affect their ovulation and the quality of their eggs. So, look at everything, but of course I'm going to be focusing on progesterone just to make sure that they did ovulate.
Wonderful.
Great.
Very specific question, but I think this one will have a pretty long answer. So, Dr. Kelly, we'll start with you on it. What is the AMH level or the antral follicle count number for which you advise women that they are likely not to be able to conceive naturally any longer?
Okay, that is a big question. I know the antral follicle count, so the AFC, it's a transvaginal ultrasound, and they're looking at all the follicles. Usually you want to see around 12 to 15. And then I don't know if I really know, like if there is a number where I say, yeah, you're probably not going to conceive. I mean, if it's below 6, that's definitely not the best sign for fertility. But you can also, usually people will test the AMH first, the anti-Müllerian hormone, because it can be a marker of ovarian reserve. And remember, you test this on day 2 or 3, and you don't want to test it alone. You want to test it with estradiol and FSH. And FSH and estradiol, always test those together, because sometimes if estrogen is really high on day 2 or 3, it'll suppress FSH. So you might get a really low FSH and be like, oh, there's an issue here, but it's just because their estrogen was so high. And with the AMH, usually we want it between like 1 or 3.
I'd like to tag on to that.
Yeah,
Yes,
go for it.
please.
I totally agree with those numbers, but I also want to say that in my experience, when I've had patients test AMH and it comes out low, it's like this doom message, right? Like your ovarian reserve is low, you're not going to be able to have a baby, you're not going to be able to get pregnant. And I would say I would recommend testing not just a one-time AMH, because I think this can change depending on what's happening with your stress, what's happening with your inflammation, and don't let that be discouraging. It gives you some information, you take that information, you adjust some things, you make some things better, and then you keep testing. Because, and even if you get super emotionally responsive to certain test results, maybe you don't test your AMH again and just continue to work on your stress, work on hormone balancing, work on progesterone and ovulatory response. Because every person that I have had come to me with a low AMH that was told you can't get pregnant from a fertility clinic, we've gotten pregnant. It's not a final sentence. So it's helpful at that time, snapshot in time. We've got some work to do. Great. All that means is it tells us where to go.
That is great. And I'll add on to that. Even women who have been diagnosed with primary ovarian insufficiency, POI, like post-diagnosis, 5 to 10% of them still spontaneously ovulate and conceive and have healthy pregnancies. So even if you have the diagnosis of POI, you could still actually have a baby. And that's why we don't call it, what do we used to call it? Premature ovarian failure, POF.
Failure.
So we don't call it failure anymore. We say insufficiency.
Mm-hmm. Yeah.
So we keep using some words like work to do and things that we need to do. So what would you say are the top 3 like reasons or mechanisms that someone might experience infertility, and what is the work that can be done about that? Dr. Debbie, let's start with you.
I say the first one is stress. I find that stress is the biggest thing. I do think genetics and environment and maybe hormone balance, also hormone balance, not just maybe, also hormone balancing is huge, but like stress, I would almost say stress, and then some other things.
Yes. Stress
How
is
about you,
super.
Dr. Kelly? Yeah.
Stress, all of us are so stressed out, especially the last couple of years. I mean, man, just in the last 7 months, I've been sick 7 or 8 times. So you can tell I also have a new baby. But let's see. So if you're in your early 40s, a lot of women are still having babies in their early 40s. I would say talk to your doctor about options now, just so you're educated. Doesn't mean you have to go through with any of them, but get educated now, and cut out or really lower the alcohol, cut out the smoking, lower the coffee to under 3 cups a day, stop using cocaine or any recreational drugs. Get your weight, gain weight if appropriate, lose weight if appropriate. Not exercising too much can be helpful. There was, and actually it was the Earth study, and they showed that a lower antral follicle count, they saw that with a higher exposure to phthalates. So look into the Environmental Working Group website and make a list of all of your lotions and potions and household cleaning products and go through the Environmental Working Group website and make sure that they're clean and they're safe. Think about brands like Tubby Todd, Pipette is great. So just do your homework there.
You said something that feels a little bit countercultural when you said don't work out too much. What do you mean by that, and what types of workouts should we be doing to prepare our bodies for pregnancy? Not mine personally, but speaking for the women that may be asking that question.
Well, Dr. Rice might have a different answer, but usually I think it can be different for each woman. But not doing HIIT workouts 7 times a week. Not lifting too much weight, not running too far, doing too many marathons. When I think about pregnancy, getting your body ready for pregnancy, I think about more kind of low impact swimming, yoga, things that can also have stress reduction in them. But it doesn't mean you can't do HIIT, doesn't mean you can't do you can't run, you can't do a marathon. Like you probably you can do some of that, just don't overdo it.
Well, and I would say it's relative to who you are, right? Like if you have not been a big HIIT or Orange Theory person, pregnancy is not the time to start. But if you've been running marathons your whole life, you can still very healthily maintain your certain capacity. But this is also like, say that pregnancy is a goal, right? We still want to look at what your capacity is for, like, what is your metabolic resiliency? What is your metabolic capacity? Everybody's going to be a little bit different. You might feel super pumped up and awesome after you do an Orange Theory HIIT, like you're 5 days a week crazy. And maybe that is appropriate for your metabolic capacity. And then you have the other person who's like, yeah, I feel like I need to recover for 3 days when I do a HIIT workout. That's not going to be free, right? Like you need to evaluate that. And if that's going to, like, you're the person that walks 3 miles a day or does more of the hiking thing, you do more swimming, you do more yoga, right? Like, and that's not to say that yoga can't be high capacity, because it can. So I don't want to have a false fallacy there. You can have pretty intense yoga, but it has to be relative to what you've been doing, what your goals are, and where you're going to go, because you can still maintain really awesome athletic capacity during pregnancy. It just has to be appropriate to your body. So
Great answers. And we are not sponsored by Orange Theory, so we will not pushing for them or telling you not to go there.
true.
Do what's best for you. On to the next question. What tests would you recommend doing for someone who is struggling to conceive but does not have any obvious hormonal imbalances, regular menses, regular ovulation, healthy thyroid, healthy weight, no weight issues? What tests would you recommend them doing? We'll start with you, Dr. Rice.
So if all of that has been tested, I would still want to look at least functional levels of thyroid, because I feel like functional medicine may look at it a little bit differently than conventional medicine. I would also want to look at cortisol. I want to look at stress. I want to look at, I have some patients that are like, oh, this is just how it is. Like, this is just how my life is. But if we test it on paper, we can see that your body is running up here, or you may also be super depleted, but you don't know any different because you've been in your body for however many years you've been in your body. So I think it's good to look at your cortisol, evaluate your cortisol, look at your stress, look at your sympathetic, parasympathetic balance. I'm also a fan of looking at environmental exposures, right? Like if you are, I feel like journaling can be very helpful. It can let us know not just like when you have certain rhythms or changes or patterns, and we're looking at sleep, we're looking at digestion, we're looking at exposures, right? Like maybe one of your hobbies is painting, and that's going to be a big environmental risk. So we want to look at what that could be. And some people don't even think of that, right? Because it's a stress reliever. It's something that you do for fun. So I would definitely look at functional ranges for thyroid, functional testing for stress and cortisol, and environmental exposures, and gut health too.
How about you, Dr.
Yeah.
Ruef?
Yeah, gut health for sure. Sometimes I look at prolactin and, of course, testing the gonadotropins, the LH and the FSH on day 2 or 3 of the cycle. Sometimes that can give you an idea of if there's an issue with the signaling from the brain to the ovaries. Yeah, the sex hormones, vitamin D, look at vitamin D. So there is research that if you're low in vitamin D and you conceive, you have an increased risk of miscarriage. So I definitely look at that vitamin D, even though it's not covered by insurance. Sometimes people can do cash pay. And then I might look into things around methylation, like MTHFR, methylmalonic acid, which we have on the Dutch test, folate, homocysteine. Sometimes methylation issues can play a role in infertility. And sometimes homocysteine will elevate if there's methylation issues, but also if there's low choline. And we know that choline is, like every woman who's trying to get pregnant, I put them on choline or make sure they're getting choline in their diet. And we know that choline is really important for that baby's brain development in utero. So choline before pregnancy, choline during pregnancy, choline during breastfeeding.
Choline.
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 Also not sponsored by choline, but
But we should be.
we should be. Next one's a little more technical question about the Dutch test. So I'll try to do my best to not just read off a bunch of acronyms. Is there a connection between 16-hydroxy estrogen metabolites and cortisol metabolism, or the cortisol metabolites? Dr. Rice, you were shaking your head, so we'll start with you.
So I think there is correlation, but I feel like Dr. Kelly, you might have a little bit more information on that.
Yeah,
So I'll let you explain that.
I think this is based off Dr. Allison Smith's webinar that she did, I want to say last month. She talked about
Totally.
this. And so CYP3A4, CYP3A4 is an enzyme that metabolizes estrone into 16-hydroxyestrone. It also metabolizes estradiol into estriol, which, a fun fact, estriol is the same thing as 16-hydroxyestradiol, which is really confusing, right? But on the Dutch test, we look at 16-hydroxyestrone, and then everyone's like, where's 16-hydroxyestradiol? And I'm like, it's right there, it's estriol. Okay, but CYP3A4, it also metabolizes cortisol somewhat. So if you have a slow CYP3A4, you might have some sluggish cortisol metabolism, but the 5-alpha, 5-beta reductase enzymes are probably more of the primary enzymes that are metabolizing cortisol.
So I'll say gentle.
Yeah.
Gentle effect.
Yeah, we'll say gentle.
A good question. If a patient had menopausal estrogen levels and they're a 30-year-old female with regular cycle, what could be some of the causes of that?
With regular cycles?
Mm-hmm.
I feel like that kind of overlaps what we were talking about with the cycle mapping. There could be, right, like just generally lower levels of estrogen, but I would also want to make sure that we're looking at appropriate timing for when we do the Dutch test. Like if it's a Dutch complete or a Dutch plus or even a serum test, we try to shoot for the best luteal range in the cycle. And if you're having about a 28-day cycle, that special day is going to be around day 20, 21, 22, depending on the person. And if for whatever reason you're having longer cycles, whether that's, a longer luteal phase or something is off, we haven't hit that appropriate luteal phase. And if it's a postmenopausal estrogen, we're probably way off target on that.
Yeah. And we mentioned earlier, if if their progesterone's within range, if they ovulated, then their estrogen had to get to a certain point for a certain amount of time for them to ovulate. So their estrogen isn't going to be in that postmenopausal range throughout the entire cycle. And yeah, so maybe look into a cycle mapping so you can see the estrogen levels during the entire collection period.
I agree with
Wonderful.
that.
So, Dr. Ruef, do synthetic progestins act more like estrogens in the body?
They actually tend to act more like androgens. And I learned this from Dr. Laura Bryden, who I love and adore. And, this is her book. If you haven't read it, it's great. Period Repair Manual. I think she talks about this in this book. So there are progestins with a high androgen index, and that's like medroxyprogesterone, which is in the Depo-Provera injection. I can never say this, but levonorgestrel. So think about Norplant, Mirena, IUD, the morning after pill, and then Norgestrel. There's a bunch of other ones. Norethindrone is one that we have heard about. NuvaRing, Nexplanon, a lot of pills. OCPs contain those. And so, yeah, those have a high androgen index. And it's unfortunate. Sometimes we actually see women with PCOS being put on pills that have these progestins that have a high androgen index and act like androgens in the body. So definitely isn't helping their symptoms of excess androgens.
Wonderful. Thank you.
Yeah.
Dr. Rice, question to you. What is the difference between synthetic and bioidentical hormone replacement therapy?
Great question. And I think that they're, in certain practices, they're used synonymously, but they are very not synonymous. When we're looking at synthetic hormones, these are made in a lab and they try to mimic the hormone structure of what our body makes as progesterone or what our body makes as estrogen. They try. And in that, with these chemicals, the reason why they end up maybe not being as effective or over effective, right? Like you get a more pronounced reaction is because of their chemical structure. They end up either binding too strongly or binding not just what we're looking for, like with estrogen, but they end up binding some other things too. And so we end up getting a more exaggerated hormone response with maybe some other reactions that happen as well. Bioidentical is where we're trying to mimic the progesterone that your body makes. When we look at the compound structure of what your body makes for progesterone, we have a plant structure that is the same. And so in that, because like everything is made in a lab, right? But when we're looking at bioidentical hormone replacement therapy, this is taking that plant structure and it's the exact same, like the way that it binds in your body is going to be the same as if your body made it. So you're getting a bioidentical or same hormone response with a bioidentical estrogen, a bioidentical progesterone. So it's going to be more of a natural binding. It's going to be more of a natural response with a bioidentical hormone replacement therapy versus a synthetic hormone replacement option.
And this is not a question somebody submitted, but it is a question that I thought of as you were saying that. When you're testing and using the Dutch test with any type of hormone replacement therapy, how do you use the Dutch test as a tool alongside of that hormone replacement therapy, both pre, with, and post? How would you recommend using the Dutch test as a tool?
It's a big question, Noah.
Oh, here's your rabbit hole. Dun, dun.
Yeah.
I think it also depends the route of administration. Are they taking it orally, topically? That's going to really change how we're going to interpret the test.
It would be nice though to like if we can have like if I could do whatever I wanted, I would love to have a baseline test, right? So we know what your body is making. And with bioidentical hormone replacement therapy, so the Dutch test measures what we call endogenous hormone production. That means what your body makes of those hormones. And if you're using bioidentical hormone replacement therapy, the Dutch test doesn't know the difference between Debbie and bioidentical hormones that Debbie is taking. So it's going to show that bioidentical hormone supplementation. If I'm testing Debbie, but I'm also taking a synthetic hormone, what ends up happening is that is labeled as an exogenous hormone. So that synthetic hormone will, we will still see the effect of that hormone, but we won't be able to see how much of that estrogen is in there, right? Because it's not an endogenous or bioidentical hormone structure. So we also have to be aware of that, right? Like, is this a bioidentical hormone therapy? Is this a synthetic hormone therapy? We still see the effect, just depends on what hormone it is.
Not confusing at all, right?
I like
So know the route of
In the world
administration.
of simplicity,
Yep.
right? Yes.
Yep.
I like that idea. Sorry, Noah, you were saying something.
No, go ahead. Go ahead.
Oh, I like the idea, Dr. Rice, that you said to do a baseline. And I had this argument in my head for a long time, like, okay, I have a menopausal woman. Should I do a baseline Dutch test? Her hormones are going to be low, right? But I've, now that I've been a consultant here for about 3 years, yeah, 3 years now, this next month. I mean, I've looked through thousands of these lab reports, and I do see it's rare, but I do see some menopausal women with estrogen, with estradiol that's in the luteal range. And with that woman, I'm not going to give her more estrogen likely. Probably going to give her progesterone to protect her uterus. Usually you see that in women who maybe have a history of PCOS, they have high androgens, and they're usually overweight. But then on the opposite, sometimes you'll see a postmenopausal woman with really, really low estradiol, like very, like below the postmenopausal range. And for that woman, I might actually start her off with a higher dose of estradiol. So I think it can be helpful to see baseline estrogen. I think it's important to at least measure it in the serum, have a measurement before.
And I would love to know how you're metabolizing your estrogens too. Like, am I putting gas on a fire? Or do we
Yes.
need to help with detoxification? Like, what is your oxidative stress? The other thing too is, I mean, this is kind of a little bit of a tangent, but when we're looking at perimenopause and postmenopausal females, we know that the adrenal glands step in, right? As the ovaries decide that they're done, the adrenal glands step in to help. And so adrenal health is going to be really, really important in understanding what you're coming to the table with when it comes to, how prepared are you for hormone transition with peri and postmenopause. So.
Yes.
Thank you for taking my rabbit hole. I appreciate I appreciate that. Dr. Kelly, do you have another question for you? This person asked and said that they have an increasing number of female clients, as well as perimenopausal, reporting male pattern facial and body hair growth. Their Dutch reports are not showing alarmingly high testosterone, which they thought would be, which they expected to be with the symptom. What do I need to be looking at differently, or is there something to balance what might be causing this uptake in females?
Okay. Okay. So testosterone and DHEA is coming back normal, but they have hair growth on their face and body. Okay, I think I'm
Yes.
understanding that correctly.
Yep.
So sometimes doing the Dutch test in these cases can be helpful because with the Dutch test, we can look at the downstream androgens and we can see how they are metabolizing their, like metabolizing and clearing out their androgens or more metabolizing. And so we know that testosterone, the active form of testosterone is 5-alpha dihydrotestosterone, so DHT. I think I said that right. um, and we do test DHT on the Dutch test, but I like to keep in mind that DHT is a peripheral hormone, so it likes to hang out in the tissues. It doesn't really like to hang out in circulation. So what we test in the urine, what we test in the serum might not be the most accurate picture of what's in the tissues. We also test 5-alpha androstenediol, which is actually a downstream metabolite of DHT. And so I have people imagine this. So imagine you've got DHT in your tissues, in your chin. And there's a lot of DHT and it's causing hair growth. That DHT is a peripheral hormone, so it likes to hang out in the tissues around your jawline. It doesn't really like to hang out in your blood or in your urine, so we might actually miss it if we test it in the blood or the urine. But all this DHT, it's being metabolized to 5-alpha androstenediol. and 5-alpha androstenediol circulates better. So we can test that in the urine. We do test it in the urine. And so sometimes if your 5-alpha androstenediol on your Dutch test is elevated, that can be a better marker of alpha activity or DHT activity in the tissues. And so, I look at those downstream androgens. I look at the 5-alpha, 5-beta index. We know that 5-alpha reductase tends to turn androgens into more potent forms that are going to cause, hair growth on the jawline, whereas 5-beta reductase is going to turn those androgens into the less potent forms. And one thing I want to clarify, because I get this question a lot, sometimes women have really low androgens just all across the board. Their DHEA, their testosterone is low, their downstream androgens are low, but they're pushing the alpha pathway. And people say, well, that's causing the acne, right? That's causing the facial hair. And I would say maybe not. Use caution there, because even though they're favoring 5-alpha reductase, they just don't have a lot of androgens in general. And so there might be a different cause. But with the facial hair, I still look at blood sugar. I still look at medications. Some medications can definitely cause that. I ask about their mom, their sister. Is it a hereditary trait? Maybe it's just one chin hair that really bothers them, So it can be really subjective too.
I would also like to add that sometimes with that, where you have this more like androgenic effect of hirsutism, like the hair growth and acne, I also like to look at progesterone, because low progesterone, like when we look at progesterone, a lot of times we think of progesterone as the balancing hormone with estrogen, but it's also a balancing hormone with the androgens too. So if you have low progesterone, and our progesterone only gets to have her little party the second part of the cycle. And so we already know that there's progesterone deficiency, right? Like normal, because you're not supposed to have it. But then if she gets her chance and she's still like, through the cycle, you're still not getting enough of this like progesterone response or balance, even with the androgens too. So you might have completely normal levels of androgens, but if you have low levels of progesterone to also help balance that, that can also influence that too.
Yeah.
I started talking and I was muted, so I appreciate the sound effects. That was really helpful as I understand progesterone. So I've got we've only got about 15 minutes left, so I've got two questions that we'll ask. One's a very specific question about the Dutch test, and one is a very broad question, but I'm sure it was submitted multiple times, so we'll try to get to it in the most efficient way that we can. Maybe you can both give me your top 3 reasons of what might be the cause of low libido and how you would see that on the Dutch test.
We should say at the same time, Debbie.
Stress.
Stress.
Yes.
Yeah,
Okay,
totally.
got it. Awesome.
Stress. Being overscheduled.
Totally. So you guys, and this is in the Merck manual. Like if you look at the Merck medical manual, and it's like males and libido, females and libido, and like males, there's like 2 things that can affect it. Females, it's like the list and just like keeps rolling.
Yeah.
You're like,
More.
oh, okay, yeah. But stress is a big one.
What might be a couple other things that you might be able to see on the Dutch test specifically and low libido that they could check for?
I'll let you go, Dr. Kelly.
Low or high cortisol, which kind of ties back into that stress. Low androgens, we know. Low estrogen. Besides, on the Dutch test, thyroid issues can tie into it. So sometimes you'll see patterns of thyroid, which sometimes we see patterns with the cortisol when it relates to thyroid. And then relationship issues. Sometimes I know practitioners ask, well, when you look at other people, are you attracted to them? Do you get turned on? Or is it just your partner? So that can be an issue too.
And for females, we also know, right? Like if you have a list of things that you're doing, right? Like a lot of times females have to know that their list is done before they can actually relax into that, like, okay, now where's my libido? Right? Like now we can activate it. So that is going to be like that mental clarity, being able to, like, some people it just takes like maybe a little bit of meditation or making sure that their to-do list is helpful. I don't know if you guys, okay, Kristen Bell and Dax Shepard, right? Like, I love them. And she just posted this thing on Instagram where he's out there like cleaning and vacuuming and did it. And she was like, this is my husband trying to turn me on. 100% true. Stamp of approval. Yes, right
It
there.
works. It works.
Totally. Like, helping with the to-do list? Absolutely. The
Yeah.
other thing that I would say though too is also progesterone. So there are some women, I mean, I know a lot of times we think of testosterone as like the hormone, and it's true. Yes, it's part of that. But there are a lot of women that are also like, man, I feel a little more saucy around ovulation, and it's because you're getting that ramp up of progesterone. So progesterone can also be influential there too. So if you're not getting a good progesterone bump, like, having that imbalance in hormones can certainly contribute as well.
You missed the
Okay, good.
opportunity for the sound effect there. I was looking for the sound effect again. But it sounds like a balancing, because that sounds what it continues to be. It's finding that balance between stress and progesterone and looking for that circadian rhythm. So that's good to see. And you talked about thyroid and cortisol, and then stress and cortisol. It sounds like cortisol is a big piece to the puzzle for a lot of us there.
Stress is
So
a thing. It's a thing.
stress
Yep.
is the thing. Yes, that's right. And then this is the last question that we'll get to today. I know we had a lot of questions submitted, and we're thankful for everybody that submitted more questions today and throughout the time that we gave you to submit those. But this is the last one we'll be able to get to today. And I'll kick this over to you, Dr. Kelly. Would you recommend the Dutch test to a teenage girl who just started her period and experiencing symptoms, i.e. cramping, acne, etc.?
You could. So she's 16. She just started her period. So it's a little on the later side for menarche to start your period for the first time. I know some people will wait about 2 years for the HPG or the HPO axis to mature more before they do testing. There goes my light. um, but if the symptoms, I mean, you could definitely test her. She's 16. Her urine, she's excreting creatinine in a way as an adult would, so the results are going to be accurate. So you can definitely test her, and if she's getting her period, then you can kind of you can kind of compare her hormone levels to, or at least her estrogen and progesterone to like a 20-year-old, but just use some caution there. So I would say if the symptoms are if they're severe enough, yeah, you could definitely test. But some people will kind of wait for that HPG axis to mature a little more. But I think
Wonderful.
Dr. Rice might have some more to say about that.
Yeah,
I'm going to mute
Dr.
myself
Rice.
because I'm going to start coughing.
No, I totally agree. I think you can still test. The information is still going to be representative. It would be my preference, to have a little bit of routine cycling under the belt to be able to have comparison. But as Dr. Ruef said, she did start a little bit later, so it might be nice to see how she's doing out the gate, and see if there's any support that you can do.
Wonderful. Well, Dr. Kelly, Dr. Debbie, thank you so much for jumping in at the last second, for showing up with getting over being sick, for Dr. Debbie jumping in and helping out. We're very thankful for all of the questions that you asked today. Don't forget, we will be sending out the information about Dr. Demiri's webinar when we do reschedule that. So if you showed up today looking for her, something came up and she was unable to make today. So thank you, Dr. Kelly and Dr. Debbie, for stepping in. And thank you all for joining us again today. So check your inboxes tomorrow for a link to the recording. If you do have any additional questions that you'd like to ask, or questions about our content, or just questions in general, please submit those to info@dutchtest.com. And everyone have a great and wonderful week. Hope you are well rested from the holiday weekend.
Thank you.
Thank you.